Hi, I'm Jennifer Foltz, Development Coordinator with Mid-Ohio Psychological Services, Inc. We are here today to talk about the importance of financial wellness, but what does that really mean? And why does it matter so much for our mental health? Let's be honest, one of the biggest financial stressors many of us face is healthcare. Whether it's an unexpected medical bill, a prescription we didn't budget for, or the fear of not being covered during an emergency, healthcare related costs can be overwhelming. That's why having the right health insurance and understanding how to use it is a key part of financial wellness. When we know we're protected, it lifts a huge burden off our minds. We're more likely to seek care when we need it, manage chronic conditions, and avoid letting small issues become big problems. Financial wellness isn't just about saving money, it's about feeling secure. And knowing your health insurance has your back gives you peace of mind. It allows you to focus on living your life, not just paying for it. Here to talk about the basics of health insurance is Kim Linhart, Vice President with Benchmark Insurance. She's here to provide a brief overview and hopefully answer some questions. Thank you so much today for joining us, Kim.
Thank you, Jennifer. I appreciate the opportunity. Can everyone
Absolutely. So
see my
we'll go ahead
screen?
and get the screen transferred over.
Thank you. Well, definitely, Jennifer, there is an association between financial worries and psychological distress. So really the purpose of today's presentation is to just review some basic insurance terminology and kind of have a high level overview of the understanding of the different types of plans. I'm going to go ahead and advance to the next page. If after the presentation anybody has any questions or concerns, if you'd like to email me or call me, feel free to do so. I'm happy to talk with you direct. Keep in mind that this is a very high level overview. It's really not possible to cover everything in a 30-minute training session. So there's always, exceptions to rules and such. So this is definitely very high level overview. So we're going to kind of look at some terminology first because that can sometimes be confusing. So a copay, or also known as a copayment, that is just a cost share. And usually that cost share is going to be a flat dollar amount. It could be per visit, per occurrence. Usually we see flat dollar copays on services like a primary care physician, a specialist office visit. Now, keep in mind that the copay may not be all inclusive. That depends on your plan. So sometimes people have an all-inclusive copay. They just go to the doctor and pay $30, while other plans, they go to the doctor, pay $30, but maybe an additional service would be an additional cost. A good example of that would be, say you go to the doctor and you end up having a mole removed. You might pay a flat dollar copay for the doctor visit, but in addition to that, because an additional service was provided, you also have to satisfy the deductible and any kind of co-insurance. Another good example would be lab work. If you are at a doctor's office, sometimes that $30 copay covers everything that happens in that visit. Other times it's just covering the office visit and other things are subject to the deductible. And I'm actually going to come back to this slide. I'm going to advance to the next slide for a minute to show you what I mean. You can see this is actually a summary of benefits, and you can see it says primary care visit as a $30 copay and the deductible doesn't apply. But notice down here on other services in an office, surgery is a $60 copay. So you might go to the doctor, pay your $30 copay, but also have a mole removed or a wart removed, which is an office surgical procedure, and there's an additional $60 copay. Also notice on labs, and on this summary of benefits, the labs are no charge after the deductible's met. So on this plan, if you go to the doctor, pay your $30 copay, and they draw, blood while you're there, it's also going to be, the blood work is going to be subject to the deductible. So this, knowing your plan definitely would benefit you. You'll notice here a freestanding lab facility like a Quest or a LabCorp, had you gone to the freestanding facility, you would have just paid a $40 copay for the labs instead of it being subject to the deductible and the coinsurance. So I just wanted to make you aware that sometimes copays are all inclusive, other times they're not. It's going to be dependent on the plan you have. But flat dollar copays usually apply to things like, as I said, the primary care physician, a specialist visit, urgent care, prescriptions. Sometimes inpatient, outpatient diagnostic services have copays. Those copays are going to be significantly higher. For example, you might have an inpatient copay of $1,000, or maybe the outpatient copay for an outpatient surgical procedure is $250 or $500. So again, it's going to be dependent on the plan that you have. Emergency room, sometimes that's covered under a flat dollar copay. For example, you might just go to the emergency room, pay $300. Other times it could be $300 plus the deductible plus any coinsurance. So again, that's going to be dependent on the plan that you have selected. Deductible. A deductible is just the amount you must pay for covered healthcare services before the insurance begins to pay. So the deductible can be on a calendar year or a plan year or per occurrence. Plan year means, say for example, your plan began on May 1st, then the plan year might be May 1st through April 30th of the next year. A calendar year is obviously begins January 1st. And then the per occurrence deductible is just on each occasion or each time that you seek those types of services. And deductibles can be embedded or aggregate. Can be confusing. Embedded means per person. So say, for example, that you have a plan that has $1,000 deductible. That's per person to a maximum of 2 people or 2,000 in the family, versus an aggregate deductible, $1,000 for an individual and $2,000 for a family. But the family deductible applies to everyone. So if you're covering you, your spouse, and your 3 children, and you have an aggregate deductible of $2,000, that means nobody has insurance coverage until the family deductible has been met. Versus if it's embedded, that same example, employee plus spouse and 3 children, if only one person in your family has to satisfy the deductible, you're just paying the $1,000 individual deductible. If a second person in your family has to satisfy the deductible, then you will have met the family deductible between the first person and the second person. Coinsurance is usually a percentage of the medical cost. Sometimes it's displayed as what the insurance company is paying. Other times it's displayed of what you're paying. Usually, if it's a larger number, that is what the insurance company is paying. So you might recognize when people say, oh, I have $1,000 deductible 80-20 plan. Usually that means the insurance company is paying 80% after the deductible's met, while the insured is paying 20%. Out-of-pocket maximum, that's the most a policyholder will pay each year for covered healthcare expenses. Once the limit is met, then all expenses are covered at 100% until the end of the calendar year or plan year, if you have a plan year. What applies toward the out-of-pocket maximum? Usually flat dollar copays, deductibles, and coinsurance. You definitely need to check your plan documents because many people are covered under grandfathered or grandmothered plans. And oftentimes on those grandfathered and grandmothered plans, because they're old plans that were in existence prior to 2010, they are not Affordable Care Act compliant, and the copays do not count toward the out-of-pocket maximum. So you definitely need to check your plan documents to see what is actually accumulating toward the out-of-pocket maximum. And again, that out-of-pocket maximum can be on a calendar year or a plan year. Calendar year, of course, means beginning every January 1st. Let me skip over that. In-network and out-of-network providers Most insurance plans do have both in and out of network providers, and benefits are different for both in and out of network providers. But in-network providers just means that the providers have contracted with the insurance company, and they have already agreed to accept the rates that the insurance company has proposed. Out-of-network providers have not contracted with the insurance carrier, and they can charge whatever they want. So usually out-of-network benefits have higher deductible amounts, lower co-insurance amounts, and then you're also subject to usual and customary charges. So, for example, if your doctor charges $1,000 for something that the insurance company says is really only worth $700, the insurance company is going to base the benefit on the $700, and they're going to apply the $700 toward the out-of-network deductible and out-of-network out-of-pocket maximum, as well as a lower co-insurance amount. That's where the phrase balance billing comes in, because your doctor, being out of network, has not agreed to what the insurance company wants to pay them. So they might balance bill you for the difference between what the insurance company allowed or is paying versus what they are charging. So an allowable charge, that's an approved dollar amount that a health insurance company will reimburse a provider for a certain medical expense. So again, even though your doctor might charge $500, if the allowed amount is only $400, they're going to base the benefit on $400, not the $500 that your out-of-network provider charged you. Drug formulary. A drug formulary is just a list of prescriptions that are considered preferred drugs. Usually the list includes both brand name drugs and generic drugs. Every carrier's list is different. Even within the same insurance company, the list can be different. So for example, United Healthcare has small group products and large group products. The drug list could be different between those products. United Healthcare also has Affordable Care Act compliant plans for small groups, as well as the Ohio Chamber MEWA plan for small groups. The prescription drug lists are going to be different between those two plans. So you definitely, when changing insurance companies, want to view the prescription drug formulary so you can see what prescriptions are on the list. Usually they're identified in various tiers, like tier 1 drugs cost the least amount versus tier 2, tier 3, tier 4, tier 5. Some prescriptions do require prior authorization, which means your doctor has to contact the insurance company and provide, additional information why you need this prescription. Some drugs have step therapy requirements, which means you need to try this prescription before they're willing to pay for this more expensive prescription. And then some prescriptions have quantity limits. For example, maybe a drug is usually written for a 10-day supply, but your provider wants you to take the drug for a 20-day supply for your condition. In that case, you might end up having to pay 2 copays. Keep in mind the list can change throughout the year, usually not too frequently, but if you are accustomed to paying $15 every time you go pick up a prescription, and one month you show up and they tell you it's $20, it's because that drug has probably changed tiers. Again, usually the lists don't change too frequently, maybe once to twice per year. Now, if you're on a prescription that is not on the drug list and your provider has good reason for that, maybe you have an allergy or it's just not working because of other medications you're taking, the insurance company can make exceptions. Your doctor would want to contact them and do a peer-to-peer review with the medical director, so they could agree on, the exception and the reason why the exception needs to be made. Pharmacy benefit managers. So they usually are the companies that are negotiating the cost and payments between the drug manufacturers, the pharmacies, and the health insurance carriers. When you go get a prescription filled and the pharmacist comes back and says, oh, this is a $30 copay, usually that claim is not hitting your insurance company's computer system. claims adjudication system. It is actually hitting the pharmacy benefit manager's system, and the benefit manager is telling the pharmacy what copay to collect based on the plan that you have. Common, pharmacy benefit managers that you probably have heard of are Express Scripts, OptumRx, Benecard, Ingenio, CVS, Caremark. Those are third-party administrators, and they work with each insurance company, and the carrier decides, what tier they want to put that prescription in. And again, it can vary based on the product that the client has purchased. An explanation benefits is a document that the insurance company sends to an individual that is explaining how the claim was, settled. It's going to show whether the procedure, was provided by an in-network provider, out-of-network, what is the in-network and out-of-network deductibles and out-of-pocket maximums. So a lot of times those are sent to your home, or you have to go to the carrier website and, view them there. But it has a lot of great information on, what is your obligation, what they paid, what your accumulations are for the deductible and the out-of-pocket maximum each year. Pre-existing condition is a health problem, injury, or illness that an individual has before signing up for insurance coverage. Most health insurance plans do not have a pre-existing condition limitation, but they do still exist. For example, you might buy a short-term medical insurance plan that doesn't cover pre-existing conditions. So again, you need to check your insurance policy to see how they address pre-existing conditions, but usually group insurance plans and plans that are true individual products purchased on the marketplace, for example, are not going to have a pre-existing condition limitation, but short-term medical policies can. Premium is the cost that you're paying each month for insurance. It does not count toward the deductible or the out-of-pocket maximum. Sometimes there's questions about that. The premium is just how much it's costing each month to buy this policy. It doesn't actually count toward any kind of deductible or out-of-pocket maximum. Open enrollment. Open enrollment is generally just the period of time that an employee can, make a change to your plan, whether that's enroll or terminate, add a dependent to the plan, or maybe you are offered multiple plans by your employer. Maybe they offer 3 different medical plans and you want to move from traditional insurance to health savings account qualified. Usually that is done during open enrollment. There is another terminology of annual enrollment that usually only applies to, say, life insurance or short and long-term disability, maybe dental insurance. Those types of policies don't have an open enrollment period. Usually open enrollment is just for medical, vision, and possibly dental, depending on the dental plan that is available. Some dental plans have late entrant penalties. So there is a difference between open enrollment and annual enrollment, even though those phrases are sometimes used interchangeably. They are very different. Open enrollment is a time when somebody can make a change and not have to prove insurability or be penalized for coming on outside of their new hire waiting period, versus an annual enrollment is when the employee can make a change annually, but there could still be some kind of penalty associated with it. For example, on dental insurance, some dental plans have annual enrollment instead of open enrollment, where you can come on the plan, but there might be a late entrant penalty that you have to deal with for maybe the first 12 months or so. Special qualifying events, those are life events that enable you to come on to an insurance plan outside of the new hire waiting period. Usually you have to apply for those within 30 days of the event. You also may need to prove the loss. So for example, maybe you're covered under your spouse's plan and they just lost their job and you want to come on your employer's plan. Well, you're going to have to prove that you lost coverage. What proof could you submit? It could be just simply a letter from your spouse's employer saying you lost coverage, or some kind of document you received from the insurance company, maybe even a COBRA notice that says that you have lost coverage, but usually you do have to prove the loss. So things like employment change, loss of coverage, maybe you are aging off of a parent's plan, maybe you're changing marital status, like you just got divorced, so you need to come on your employer's plan, you've got to prove the loss. Maybe you want to add a dependent. You just had a baby, and that's a special qualifying event to bring the baby on the plan within that 30 days. Maybe your employer has multiple locations all over the country, and you kind of lose insurance because you're no longer in a zip code that is covered by that insurance plan. So if you change residence, that could also, end up being a special qualifying event. Or of course, in the event of death, maybe you're covered under your spouse's plan, your spouse passed away, and now you'd like to come on your employer's plan. Those are all considered special qualifying events. So there are different types of health insurance plans. Employer-sponsored is common. On an employer-sponsored plan, obviously the employer is going to decide what to offer and whom to offer it to. Usually there are eligibility requirements. A lot of times that's based on the number of hours that you're working to be eligible, or it could also be geographically. Maybe people in California are eligible, for example, for a different health plan than the people that are located here in Ohio. The employer usually has to contribute toward the cost of the insurance. They may not have to contribute toward the cost of dependent coverage, but usually they do have to contribute a certain percentage toward employee cost. Usually that number is 50% of the employee cost, at least 50%. They can pay more if they want, but at least 50%. And then, of course, there's individual health insurance plans or private insurance. That's usually insurance that you're purchasing on your own, as opposed to purchasing it through an employer or a government program. On individual health insurance, usually that's for people that are under the age of 65. There is an annual election, which usually is it happens in November and December for a January 1 effective date. The open enrollment period is November 1st through December 15th. You could purchase an individual policy either off the marketplace or on marketplace. For you to obtain a subsidy, should you qualify based on household income, you would have to purchase that on the marketplace. But there are truly plans that are both considered on and off exchange. Off exchange plans tend to be maybe a little richer benefit with similar cost. So if you're somebody who doesn't really qualify for a subsidy, it might benefit you just to buy off exchange, because for the same dollars, you might get a little better plan and you don't qualify for a subsidy. Usually the individual policies are Affordable Care Act compliant, which means that they are meeting the metal level standards set. So for example, you have an opportunity to purchase a platinum plan, gold, silver, bronze, and each plan has an actuarial value attached to it. So for example, a platinum plan is designed to pay the average person 90% of the average person's medical expenses, while gold is designed to pay 80, silver is 70, and bronze is 60. Usually these individual policies are community rated, which means that it doesn't matter what your health problems are. The rates are just age-based. And then it is guarantee issue if it's purchased both on and off exchange. So as long as you're applying during the open enrollment or you've experienced a special qualifying event, you're guaranteed to get the individual policy. It is age rated, so younger people are going to pay, quite a bit less than older people. They can also surcharge you if you're using tobacco. One of the negatives on the individual policies is that the networks are definitely narrowed. So if you're buying, for example, an Anthem individual health insurance plan, it is not the same Anthem network that an employer usually has access to while offering a group plan. So the networks are significantly smaller. A good example would be Medical Mutual. You're not going to get the full-blown Medical Mutual network on an individual policy. It is going to be more like just Ohio Health. So if you have children, for example, maybe Medical Mutual isn't the best option for you because you want Children's Hospital to be in the network. So just be aware that on individual policies, the networks are not the same networks that you're accustomed to when purchasing group insurance. The prescription drug list on individual policies are also more limited. A lot of the drugs just don't appear on the list, or they might be in higher tiers. Or they might be subject to deductible before copays apply. So just make sure that you're researching what tiers your prescriptions fall in and if they're on the list or not. As I mentioned, short-term medical insurance policies, they are different than the regular individual policies purchased on and off exchange. Usually the short-term medical plans are subject to medical underwriting. So usually these are people that are healthy, don't really have any major health conditions, and the insurance company can decline you if they don't like the conditions that you have. There are pre-existing conditions to consider. Usually you purchase these short-term medical plans for a duration, like you could purchase it for 30 days, 60 days, 90 days. They do cost significantly less than private regular individual insurance plans because, again, they won't cover pre-existing and they're meant to be short-term. You can be denied. Everybody who applies is going through medical underwriting. So usually they do cost less and should just be purchased for short-term needs. Medicare is usually for the 65 plus crowd. If you qualify for Social Security disability, you may qualify for Medicare even though you're under age 65. There is a waiting period of 29 months before you would actually qualify. Part A is generally free for most people. Part B does have a premium associated with it, which is based on household income. So people who are earning more end up having to pay more. You may want to buy Medicare Supplement. I think that Part A and Part B are really designed to cover about 80% of the medical expenses, and the Medicare entitled individual is paying 20% of the medical expenses. Well, you may want to buy a Medicare Supplement to cover that 20% responsibility. You also would want to purchase a Part D prescription drug card, which is completely separate. Medicaid is a joint federal and state program that helps cover the cost for some people who have limited resources. Usually people that are low-income adults, children, pregnant women, maybe elderly adults, and people with disabilities may qualify for Medicaid. Types of plans. When I think of the types of plans, I think of kind of like traditional insurance versus HSA qualified. There are also some indemnity plans out there as well. But to kind of describe what I consider a traditional insurance plan, that's usually a plan that features office visit copays, maybe copays on urgent care and prescriptions. So let's say that the policy goes into effect on May 1st and you need to go to the doctor on May 5th. Usually traditional insurance plans have a copay. You're just going to pay your $30 copay on May 5th. And hopefully it's an all-inclusive copay and you don't have to pay anything additional. there can be modified versions. For example, on traditional insurance plans, specialist visits can be subject to a deductible before the copay begins. So you do want to pay attention to that. Emergency room is another example, whereas instead of a flat dollar copay for emergency room, it may be subject to the deductible first, then the copay, or the copay plus the deductible and coinsurance. Most plans will cover age-appropriate preventative care with no cost share. Grandfathered plans may have a cost share. So when healthcare reform was passed, it said that age-appropriate preventative care was going to be covered at 100% with no cost share. But grandfathered plans and grandmothered plans are not subject to that same requirement. So on those plans, you could still end up paying a cost share for preventative care. Some of the traditional plans can be paired with a health reimbursement arrangement or a flexible spending account to cover things that the insurance isn't covering. And then we have health savings account qualified plans. Usually health savings account plans are considered high deductible health plans. So it's kind of a two-pronged approach. You've got your high deductible health insurance plan, and you have also opened up a separate health savings account. On a health savings account qualified plan, usually all services are subject to the deductible before any coverage begins. Really, the only exception to that is preventative care is covered at 100% with no cost share. Some of the newer plans might cover some preventative prescriptions with no cost share, but you definitely want to pay attention to your plan documents. To be eligible to open up an HSA, you cannot have any unpermitted insurance. So, for example, if you are covering yourself and you're also covered under your spouse's plan, if the spouse's plan is also HSA qualified, then you would still be eligible to open up your own HSA account. If your spouse's plan that you're covered under is not HSA qualified, maybe they have traditional insurance, then you would not be eligible to open up an HSA because you have an HSA qualified health plan through maybe your own employer. So you do have to have no unpermitted insurance to be eligible to open up an actual HSA. Every year, the government sets what the maximum contributions are going to be. In 2025, you can see that self-only coverage, the maximum HSA contribution is $4,300. If you have at least coverage for you and one dependent or more, the max for 2025 is $8,550. And if you are 55 plus, you qualify for a catch-up contribution of $1,000 per year. Sometimes I find that employers will have kind of an HSA, HRA stacking concept, but generally you have to satisfy a minimum deductible to still be eligible to open up the HSA, even though the plan also might be paired with a health reimbursement arrangement. And that minimum deductible amount for 2025 is $1,650 if you have single coverage and $3,300 if you have family coverage. And then there are indemnity plans, which usually will just pay you or the provider a fixed amount. On indemnity plans, there's generally no network. So you can go to any provider that you want, but the insurance company has already pre-established what they're going to pay for each service. And they'll either pay the provider or they'll just pay you, and it's your responsibility to pay the provider. So this is just a side-by-side comparison of what traditional insurance versus HSA qualified it may look like. Again, this is just one plan. There are lots of plans out there, but I chose to show a $5,000 deductible. This is an embedded deductible, so it is per person to a maximum of 2 people in the family for a $10,000 family maximum deductible. Once the deductible is met, this insurance plan is paying 100% until you hit the out-of-pocket maximum of $8,000 for an individual, $16,000 for a family. So any kind of inpatient stay, outpatient procedure, major diagnostic testing like MRIs, CAT scans, durable medical equipment, those types of things are going to be subject to the calendar year deductible, and then most likely paid at 100% until the out-of-pocket is met. Now, on the traditional plan, there are flat dollar copays. It's $30 for an office visit, regular office visit. So that's your primary care physicians, usually pediatricians and OBGYNs. Specialist visit on this plan is $60. And then, as I already said, inpatient and outpatient is covered subject to the deductible, and then covered at the 100%. Emergency room has a $550 copay, but it is also subject to deductible. So this is not a flat dollar copay. It is a copay plus the deductible. Urgent care is a $75 flat copay. Preventative care we're seeing is covered at no cost share. It's 100% covered. And then this plan has the copays on prescriptions. And you can see there's actually on this plan 2 levels of pharmacies, level 1 pharmacies and level 2 pharmacies. So maybe Walgreens is covered under level 1 pharmacies while CVS is level 2. So you definitely need to look at the list of preferred pharmacies as well. But on a traditional insurance plan, again, this is not grandmothered or grandfathered. This is traditional insurance plan. So everything is counting toward the out-of-pocket maximum. So if we just look at an individual covered, the $5,000 is counting toward the $8,000 out-of-pocket maximum. And every time the individual paid a $30 copay to go to the doctor, or $60 to go to the specialist, or maybe they paid $75 to go to urgent care, or they paid for copays for prescriptions, all of these copays and the deductible is counting toward the out-of-pocket maximum. Again, grandmothered plans and grandfathered plans do not work that way. So you definitely want to check your plan documents to see what is accumulating toward the out-of-pocket maximum. Over here, we have an HSA, a sample HSA qualified plan. And you can see this plan has a $5,000 deductible. It is still embedded. So it's per person to a maximum of 2 people in the family, so $10,000. Once the deductible is met, the plan is paying 100%, but it has copays now on prescriptions. Everything else is subject to the deductible, with the exception of preventative care is covered at 100%. But after you've satisfied the deductible, now you get to just pay a copay for a prescription. And if you happen to spend $3,000 in prescription copays where you meet the $8,000 out of pocket, then this plan would convert to 100% paid afterward. So there are also lots of acronyms that you might have heard. There's PPO plans, POS plans, EPO, HMOs. It can be confusing. So I wanted to put down, what the common structures are. You can see preferred provider organizations usually have both in and out of network benefits. Usually a primary care physician is not required, so you don't have to appoint a primary care physician. Usually you can go to any provider that is in the network. You don't need a referral to go to a specialist. So I consider preferred provider organizations, or PPOs, offering the most flexibility to the insured. Exclusive provider organizations, or EPOs, usually these are much smaller networks. Usually there's only in-network benefits. So if you're going to an out-of-network provider, there is no coverage. The only exception to that would be if it's an emergency situation. Then, of course, you should go to the nearest emergency room. So after the fact, they'll kind of work things out with the hospital. But in general, there are no out-of-network benefits on these EPO plans. Sometimes a primary care physician is required to be appointed. But usually you don't need a referral to go to a specialist. You can just pick a specialist in the network and go without a referral. So this plan does offer a high level of flexibility, but not as much as the PPO type of plan. A point of service plan usually has both in-network and out-of-network benefits. Usually a primary care physician is appointed or designated. If you need to go to a specialist, usually you're going to get that referral from your primary care physician. If you don't get a referral, it may still be covered, but maybe you have to pay a higher amount, either a higher copay amount or a higher percentage amount. So I would consider this one a kind of a moderate level of flexibility. And then, of course, HMOs, health maintenance organizations, usually they have in-network benefits only, except for emergency care. And then you do select a primary care physician. You would need to always go to them first before moving on to a specialist. You're going to need a referral to go to a specialist. And I would consider this as the lowest level of flexibility in a plan. So that's all I have for you today. I appreciate the opportunity to participate. So back to you, Jennifer.
Thank you so much, Kim. Before we wrap up, I want to just extend a heartfelt thank you again. You provided such useful and necessary information to help us better understand and navigate the often complex world of health insurance. So we appreciate you joining us today and sharing your time, knowledge, and expertise. Just know that you've made a meaningful impact, and we are so grateful for it. So thank you.
Thank you, Jennifer.
This workshop was provided by Mid-Ohio Psychological Services, Inc., a nonprofit community mental health care agency who strives to provide whole person wellness for those in our community. Please check out